Assalamu alaikum, this is Shamama. So sorry, it was a technical problem because of which the video stopped of management of dysmenorrhea. So this is the part 2 of management of dysmenorrhea video. So we were discussing on some of the differentials that we'll find when we were examining the patient of dysmenorrhea. So if we found that her uterus is abnormally enlarged, then we have a diagnosis of either fibroids, maybe it's caused, or if endometriotic nodules are seen, are felt, sorry, uterus is fixed, which indicate pelvic adhesions, or pelvic mass, that is endometriomas. So these three differential findings, that is endometriotic nodules, uterus fixed, or pelvic mass, these are characteristic signs of endometriosis. So we can easily make the diagnosis in that, so plus some further investigations support it. Second, if we find discharge in on examination, then we have two major differences in our mind, that whether it can be pelvic inflammatory disease because discharge is present in it, or whether it can be because of IUCDs because they also cause vaginal discharge. We can also see rudimentary horns of the uterus within the examination, and there are some red flag signs in the expression of dysmenorrhea. Now these red flag signs are some very, you can say, severe signs or alarming signs. What are they? If a patient presents with persistent intermenstrual bleed or postcoital bleed, one, or if there is a pelvic mass that is not obviously the uterus, or if the patient is having abnormal cervix on examination. So these are the red flag signs. Now we'll talk about the investigations of a patient with dysmenorrhea. So what are these investigations? First, since we know that infection can be a cause, so we go for high vaginal swab and endocervical swab. Now both these swabs we do for finding out that whether in the secretions or in the genital area any infectious agent is present or not. Fine. Thirdly, we go for transvaginal ultrasound. Now, why we do in those patients in which we have a suspicion of either endometriosis or adenomyosis as an underlying pathology. And if we have adenomyosis, then we'll see enlarged uterus plus heterogeneous texture of the uterus. And fourth modality is the diagnostic laparoscopy. Now, we don't do diagnostic laparoscopy in every patient of dysmenorrhea which comes to us. So we have some particular indications when we go for diagnostic laparoscopy. First, because of patient. If the patient is demanding exact clear diagnosis of her disease, of her condition. Second, if she wants a clear evidence that her pelvic is normal, then we go for diagnostic laparoscopy. Or when we have done some swabs and the transvaginal ultrasound and it shows normal results, but still the symptoms in the patient persist, then we go for it. Or if I being a doctor has a suspicion that endometriosis may be in my patient, then I go for diagnostic laparoscopy. And an important point, it is not performed for primary dysmenorrhea. Lastly, if the cervix on examination I saw that it is stenosed, there is cervical stenosis in the patient, then of course I can't see it further the cervix, the inside of the uterus. So for that case we have another modality, that is ultrasound guided hysteroscopy. So it's basically same as endoscopy, but the name is changed here because we are visualizing the uterus, so it's hysteroscopy to investigate further. This is all about my topic on dysmenorrhea. I've compiled and concluded my topic on dysmenorrhea. So I hope you like the video. If you do so, please like, share, subscribe and comment on my video, and do share it please max with all your medicos you know, because it will help them a lot. So thank you very much. Allah Hafiz. See you in the next video.